This is Dr. Katz. He works at Academy.
Yeah.
Stephanie was going to introduce him, and he lives in Sandy Springs. I know that, and has 2 kids. And what else do you want him to know?
Yeah, I'm Jonathan. I grew up in Roanoke, Virginia. I went to UGA undergrad, Medical College of Virginia for medical school, then fortunate enough to match in Charleston at MUSC.
Oh, there you go.
Did my orthopedic residency there, and then did a hand fellowship at the University of Iowa, and then moved to Atlanta and been doing hand here since. I'm at Academy Orthopedics. We have offices in Cumming, Duluth, and Beaufort, so more north, and yeah, it's been great. I'm really appreciative you guys having me here tonight, and hopefully we all can learn a little bit and have a good time. Hopefully I don't bore you to death too bad.
We appreciate you coming.
Yeah, absolutely. Hopefully my talk's not too technical. It's a little technical, but I figured you didn't want me to tell you how to be a hand therapist. You already know how to do that amazingly well, and it's kind of more of a orthopedic type talk. And feel free to stop me and interrupt me and ask lots of questions if you have any, and if you don't have any, that's fine too. Stephanie asked me to talk about kind of a newer, more newer technology in hand surgery about intramedullary nail fixation of hand fractures, which is something that I've kind of jumped on the bandwagon and become a big fan of using. And I'm not sure who has seen anybody with them or heard about them, but this is kind of my talk. Anybody had patients with them yet? Nope. Okay. Well, hopefully we can learn a lot, and thanks much for having me. I don't have any conflicts tonight. You know, this is definitely a more of some industry stuff, but I'm not getting paid by anybody, and so no conflicts. A little bit of an outline of what's to come. Some intro stuff, some basic science, some anatomy. We'll talk about metacarpal fractures and phalanx fractures. A tiny bit about screw design, just on a brief level. And then the meat of, you know, what is intramedullary nail fixation of hand fractures and why I love it so much. So the incidence of hand fractures, it's about 10% of skeletal trauma. Obviously, probably the distal phalanx is the most common. You know, everybody's got a friend or themselves that have squashed their distal phalanx in a car door or a drawer. Who knows what, I'm still recovering from mine. Metacarpal is probably second most. They're probably 40% of all hand trauma. Obviously, you know, the 5th boxer fracture being the most common. Super common in young men. They just love to get drunk and punch walls. So see a lot of that. What did you say?
It always involves a girl.
Yes, that's actually my joke typically. You know, I walk in and say, what was her name? And they look at me and they're like, how did you know? Like, I've seen this before. It's like a record.
Oddly enough, I had one person who actually fell on a fist.
Sure they did.
So, it was icy and
So the metacarpal itself has a concave volar side. The small and ring fingers are quite mobile, but the index and long fingers are pretty stiff. They create that, you know, really stiff pillar. You know, you'll notice true boxers, you know, they don't ever get boxers fractures. They always break the base of their index or long CMCs because, you know, they're properly trained on how to make a punch, unlike the kid who punches a wall. Hey, welcome.
Hi, thank you.
Yeah. So to start, metacarpal head fractures. Just briefly, you know, these are not common. I don't see many of these. Typically, they're more likely to occur in the border digits. Treatment's complex and definitely have to be individualized, not very cookie cutter. There are a lot of times comminuted, some are shear. The shear fractures typically do much better with fixation, ORF. You know, some you can get lucky and try to pin. Sometimes you have to do an X-fix. Occasionally you can try to splint them. You guys come in very handy with those. If they're really blasted, you know, sometimes we do a joint replacement and arthroplasty. If that fails or that's not an option, you know, sometimes a fusion and a labor is a better option. Lots of complications when it involves the joint. Lots of stiffness, avascular necrosis where the bone dies. Not a great thing to have a head fracture, which is usually intra-articular. Here's an example of a shear type fracture. Clearly a giant step off in the joint, not a good injury, really terrible. Really just one treatment option unless you're 90 and not doing much. And that would be fixation, ORF, fix it. Try to reduce the cartilage back so there's not a giant step off there. Not a common injury again. More common, neck fractures, right? We all see these all the time, boxer's fractures. The young drunk guy, right? He hits things, fight with his girlfriend. Most common, fourth and fifth metacarpal necks. They usually have this apex dorsal fracture pattern because of the pull of the intrinsics, and usually a good bit of that volar combination, if you remember the earlier slide with the concave bow, the metacarpal. So they have that apex dorsal appearance. So, it's bent dorsally, and that's kind of a typical radiograph appearance of them. So remember, the small and ring CMC joints are super mobile. You can try it on yourself. Tons of mobility there versus the index and long, or just that really strong, stiff pillar with minimal mobility, which we'll circle back to in a minute when we start talking about how that affects treatment. So for index and long fingers, we don't tolerate a ton of angulation on the x-rays before we start recommending surgery versus non-operative type treatments. 10, 15 degrees, not a ton. A few different treatment options. Obviously, if non-operatively, you're splinting if it's not bad. When they start to get really angulated, we think about pinning them, CRPP, ORF, plates and screws, and then a sneak peek of to come, intramedullary nail fixation, IMN, which is what we'll talk about a little more later. Ring and small fingers, huge variation in the literature and what's acceptable of non-operative treatment. 30 to 40 degrees angulation in a ring, 50, 60, 70, 80, 90, who knows, in a small finger. For splinting or non-operative, some people are advocating just buddy taping these and say, good luck, see you later. Surgical treatment options, obviously pin them, plates and screws, and then a newer technology that I've, again, come to love would be intramedullary nails. Historically, these young drunk guys that like to punch things, and because there's so much hypermobility there, they can tolerate a good bit of angulation, and we just say, hey, this will be deformed, but at a year, your function should be pretty good. As well, historically, the fixation options, most commonly people are pinning these, and I don't know about y'all, but I hate pins. I can't stand pins. They get infected, they loosen, they get stiff. You can't do early motion, tendon adhesions, you name it. They were just not great. So again, 40 to 70 may be acceptable. That's a huge range. And Flat did a landmark study where he said to look for the pseudo clawing that can occur, where you get that classic, MCP hyperextension, PIP flexion when they're really angulated. And so maybe for a 25-year-old laborer who just is like, hey, I just got to get back to work. Okay, fine. So I think it's a lot of individualized conversations with patients on what their expectations are, what their financial situation is. Are they insured? Are they uninsured? Are they poorly insured? To try to figure out how best to treat these patients. That's the hard part, I think. You guys, I think, doing a phenomenal job assessing for rotation. That's certainly one thing that can be missed. So if you have a patient where their cascade is off, they're scissoring, certainly let us know if we missed it, because that's a problem that should be addressed surgically. Yeah,
if
sure.
If they're doing that post-surgically, what do you do, aside from buddy taping? Because I have a couple of patients who are doing that, and it's pretty severe.
Yeah, sometimes, we're human. We make mistakes, and occasionally we can get, a developing malunion where they have scissoring. Certainly try to buddy tape it and see how they do. The small finger is very forgiving with some malrotation. Typically, we let it heal and see where the dust settles and how much of a functional impairment it is, and then if it needs to be, do an osteotomy to rotate it out of the scissor.
Yeah, I figured as they're learning to move that hand again, that things will kind of come back in place, but just wondering.
Small finger particularly, I think, is more forgiving. I've had a few that have had small malrotations like external rotation, and I think that's way better tolerated than, say, like an underlap or an overlap. So I think it's individualized. A little bit of external rotation, long term, probably okay versus big osteotomy type surgery to correct it. Yeah.
I heard you say that the little finger is very forgiving.
Well,
I find it like, oh no, it's a fracture of the digit. It always gets stiff. It is like, I feel like it's the stepchild of fingers.
so 100% it's the worst for stiffness.
Yeah.
It's because of its mobility. I think it's a little more forgiving if you have a little bit of a rotational malreduction surgically, or even non-surgically. Patients that have a little bit of alteration of their cascade, and we're like, do we fix this? Do we not? Do we just see how you do with some therapy? But certainly, small finger does not like to be messed with. Small finger PIP, just gives me nightmares, right? I have a patient that on Thursday I'm fixing. She has, this little tiny avulsion fracture of her central slip. I'm like, oh gosh, do I really have to fix that? But she's already, got this boutonniere posture. I'm like, So of course I'm gonna pin it. I hate pins. It's not gonna go well. But I try to lay some crepe, and thank you guys for your aftercare. The bone problem is the easy part. It's the therapy and the aftercare that's the hard part. So thank you guys ahead of time. Boxer fractures, reduction maneuver. Has a classic name. Does anybody know what the name of this is? It's called a Joss maneuver. And you basically flex the MCP at 90 and then just create that 3-point pressure to get it out of that angulation. So they're very easy to reduce acutely in the ER. The problem is, as soon as you let go, they fall back. And you can't splint somebody like this, right? They would not like that very much. So pinning techniques. Again, a little more technical, so just a glossy overview. So, if you're going to fix a boxer fracture historically, and a 20-year-old who punched a wall when they were drunk in a fight with their girlfriend, can cross retrograde, or you pin to their neighbor that's not broken. But can you imagine these young kids walking around like that? They don't like it very much, and they're just trying to get back to whatever they were doing before. So there's also a bouquet technique, which technically is hard. Historically, you'd bend your wires yourself and make this 3-point bend and drill a little hole in the base of the metacarpal, and you slide it in, and then you turn them, and to try to get that bend to get the fracture out of that angulation is technically hard, really hard, but it's a good option. Certainly people that are more skilled than me are really good at those, probably with more gray hair than I do. At one point they came out with some off-the-shelf versions of that, but I don't think they're still on the market. I think they got recalled or something, but they were very popular for a while, so you may have seen patients with those. The off-the-shelf ones almost always required a second surgery for hardware removal. They couldn't stay in. They had this little clip thing in the back, and they usually had to come out later, versus these are, when you make them yourself, just pull out in the office. but technically hard surgery to do. And then just a sneak peek. What I've come to be a big fan of is this intramedullary nail fixation technique. And so we'll discuss that more here shortly. Shaft fractures, again, usually apex dorsal, just like the neck fractures. Many times can splint, treat these non-operatively. I really like orthoplast splints and motion for the more stable type fractures. Much less acceptable angulation than, say, a neck fracture, I think, overall. So what are kind of the operative indications? I think, again, if the cascade's off, they should be fixed. If they're open, they probably should be fixed, even though there's maybe a tiny bit more tolerance for non-opping some open hand injuries versus like a femur. Really crooked or multiple fractures like that patient, I think should be fixed. Polytrauma, if their hand, their wrist, their leg, everything's broken, we try to fix everything so that way they can rehab much quicker and easier and not dealing with splints and things. And then, knock on, unfortunately, I'm not at Grady. I don't see many gunshots these days, but lots of bone loss and gunshot injuries. These are tough to manage, not only for the bone, but the soft tissue is usually a huge problem. Fixation techniques, again, if we're pinning, just like the prior slides, cross pin them. You can do a bouquet technique. You can stabilize to the adjacent metacarpal. These longer oblique fractures, you can do lag screw fixation. We'll talk a little bit more about that in a minute. Those are nice because you can rehab those much quicker, but it's not very common where you get just a great long oblique fracture pattern to do that. Certainly plates and screws, been around forever. And then, this newer technique, intramedullary nail fixation. Questions before we kind of change gears? Cool. Next, proximal phalanx fractures. Super rare, not that rare, but more rare would be like head fractures, these splitting and shear ones. These are almost always need surgery. So kind of all say about those. More common are these extra-articular proximal phalanx fractures. A lot of times they can be splinted and treated without surgery, especially if there's no alteration in the cascade. I really like hand-based splints for these. Get them sticky after a couple weeks and start some fairly early motion. Can split and buddy tape. It's harder to predict when the fracture pattern is unstable. Certainly some gray areas. Classically, the transverse fractures that are more towards the base with lots of angulation or shortening are more unstable and frequently we fix. Pinning, plates, screws, maybe we should be trying to nail these more. Some pinning techniques can do retrograde or antegrade cross pinning. A technique that I do like that you guys hate is this Eaton-Belsky technique. When the fracture is really close to the joint, I think it's very hard to get a good starting point. And so a lot of times I'll just pin the joint itself with 2 parallel wires. And then they come to you and they're like, why can't you move your MCP? And I'm like, oh shoot, I gotta pick up the phone, call the therapist. Hey, I pinned their joint. So if you ever see 2 parallel pins, that's what happened for the patient. And again, you guys hate these because you can't move their MCP for a month or 6 weeks, which gets them really behind the 8 ball. So here's an example of that technique that I did. Nice strong fixation, but again, the joint's pinned, which is a bummer. And I hate pins. Plenty of plating opportunities out there. I mean, every hardware company has a different cool plate that they try to sell us. A million techniques and varieties. But plates, as we all know, they get so stiff and the tendons get stuck, and then we talk about hard removal and tenolysis, and that's more surgery. And just not great for anybody, especially the therapists involved. You guys are amazing cheerleaders, and it's hard. So we try not to plate hand fractures when we can, but sometimes we have to. So again, that's phalanx fractures. Before we change gears, does anybody have any questions? We're getting so close to talking about intramedullary nails. Nobody? Cool. Just a quick overview of some screw basic science, screw design. I think it will help you understand the concepts of intramedullary nail fixation of these fractures. And, this is, I guess, ortho hand surgery in a nutshell. Dainty things with big, strong guys. So cortical screws are, the most common screws that we use. They have, the smaller pitch and thread diameter. They're made for cortical bone, that hard outer bone, versus cancella screws on the bottom. They have that much larger pitch. It creates more increased pull-out strength in the softer cancellous bone. That's just a femur for example purposes. I know we're all hand people here. There's also what's called locking screws. Locking screws are fairly newer technology, not that new, but they have this smaller thread pitch and diameter compared to like a cancella screw or a cortical screw. And what's really cool is the head itself is threaded, which allows it to lock into the plate. It really creates a really strong, stiff construct. So this is what you see in distal radius plates. These screws are all locking screws, and especially in osteoporotic women, which commonly break their wrists, that metaphyseal bone is really soft, and so this has revolutionized, the volar locking plate, how to fix distal radius fractures. Let's see if we can watch a little quick video. This is like the classic video that allowed me to understand how locking screws work.
Has
That's really loud.
completely transformed how we support customers. It's built in a
Volume go down.
I think basically what you can do is show like 2 screws going in. Actually, I think maybe the next screw I'd say just push in.
Recording your voice by the way.
Well, they're not going to hear my voice.
Awesome.
Hang on. Does anybody know how to get that over?
Pull up on another tab and you gotta exit that screen share.
Here we go. So this is an apple, and that's a plate and screws with just regular cortical or metaphyseal screws. So those are just the regular screws you saw earlier, and just pulls right out. So now they're using a locking plate and screws. So these screws again lock into the plate.
oh, okay.
So really cool technology. I don't know, probably came out in the late 90s. Super common for, metaphyseal type fractures, proximal humerus, distal radius.
So how does that work?
So let me show you again on here. So the head of the screw has threads, and the plate has threads as well. So the head locks into the plate. So it makes this really strong, stiff construct. It's designed for metaphyseal, osteoporotic type bone.
Does it lock it? I mean, the apple could have pulled away, right?
It did eventually.
Yeah.
And so these fail, obviously. We have failures, but not like before. So
Locking to the plate, but why did it keep the apple? I mean, is there something more?
I mean, the screws are threaded. It just makes the construct super stiff, super strong. So it's a very powerful tool in our arsenal. That's why, before the late 90s, the old school plates for distal radius fractures, they were just not great. They failed. They didn't do well. Yes?
So, you get maybe a 65, 70-year-old woman with a wrist fracture.
Yeah.
She's got soft bones. Put this in her.
Uh-huh.
I mean, the thing is really stable.
Yes.
Do you cast her too?
Never.
Okay. And so you can start some early motion.
I always start early motion around 2 weeks.
Because what I don't understand is when they come out of their casting, they got marks that they've got a plate in there, and then they're really stiff with it. Anyway, so that allows you to do that.
Correct.
Okay.
So before before the 2000s, before volar locked plating for wrist fractures became vogue, the plates failed often, especially in osteoporotic women. Yeah, they did terribly. So they were like, maybe we should just be pinning all these or X-fixing all these. The treatment was gray, and now it's everybody gets a volar plate until it fails too. So now you've probably seen some bridge plates. Who's seen a bridge plate? Anybody? Dorsal spanning plate, yeah. So I think it's like the modern version of an X-fix, so like an internal X-fix. And so for my really unstable fractures, high energy fractures, I think it's a powerful tool when this isn't a good option. And sometimes it's not, but 95% of the time I think it's the gold standard. Other questions? Yeah.
So the first video we saw where the apple and the pins pulled, well, not the pins, but
Screws.
the screws pulled out
Yeah.
very easily.
Yeah.
Just
So that was like these kinds of screws. So they don't lock into the plate, and so they just would pull out of that weak bone.
Was it designed that way?
Bad.
Okay, that's bad.
It's these are designed for cortical bone. So this is a cortical screw versus these are locking screws. See the threads are very different, and so you can see here the threads are very different, and the head's not threaded.
Have you ever seen that in practice where they would come out like that?
Yeah. Absolutely. Yeah. Plates fail. Surgery is not benign.
And when you say fail, is that the best example of a plate failing, or what else would?
I mean, that was be in a dramatic fashion with the apple, but yeah, sometimes that happens, especially in proximal humerus fractures, which is the apple is supposed to be a shoulder, a proximal humerus. Other questions?
How long after surgery did you see? I've never seen one fail, but how long after surgery would you see them fail typically?
It depends on the bone.
Okay.
Distal radius fractures frequently fail within the first 2 to 6 weeks. I would say that's probably true for many. I had a humeral shaft fracture that was doing really well. And then at like 6 or 8 weeks, she started to get some screw loosening. But then she ended up going on to heal. It's a biology race. These are meant to provide a structural scaffolding for the bone to heal. And so the plates are metal, so they will fail no matter what if they keep moving over time. And they're designed to move, right, to stimulate fracture healing. And so the analogy I would use would be like a paper clip. So, if you bend a paper clip enough times, it's going to break. So same with these things. And so either the plate will break or the screws will pull out or both. More common for distal radius fractures is, when they're intra-articular and involve the joint, they'll settle. These screws are supposed to be as close to that joint line as possible when they involve the joint to create almost like a rafter support. Does that make sense? So say, it's from the joints here and the screws are here, they can only settle a little bit, but if your screws are way down here and they settle a lot, then the screws can end up inside the joint. So that's what you really don't want, which unfortunately, again, sometimes happens. Yes?
So that will peek into the space, joint space, that does not cause a problem?
This one?
Yeah?
So it's actually into the radial styloid. It's just the X-ray angle. It's a 3D thing with a 2D X-ray. But it does look like it's in the joint, but you can see this shadow right here.
Yeah.
That screw is going into the radial styloid over there, versus these all go straight across.
Gotcha.
So it's angled differently, but it is
Thank you.
subtle.
So Jonathan, when they
Yeah.
fail, you remove them?
Yeah.
Do you replace them or do you?
So ideally, you try to get it so it heals, and then you take everything out. Sometimes that's not an option, and then you got to start over. So I had, it's been a couple years now, one guy, really bad intra-articular fracture. I probably should have bridge plated him, but I think I was too overconfident that I could do it with a volar plate, and he settled a lot, and one of the screws ended up in his joint. But we waited for him to heal, and at 3 months took everything out.
So what is settling?
So think about like a crack in your house foundation, okay? Over time, it's gonna settle. So same thing, when you break your bone, over time the tendency is that it settles, especially in that weak metaphyseal bone. It's not strong, especially in, osteoporotic women, which are these are distal radius fractures are the most common population that we see.
Very quick question.
Sure,
is that,
yeah.
When hardware is removed,
Mm-hmm.
doesn't it disturb the healing and maybe create problems? I don't.
So the holes can create stress risers, which is temporary. The holes will fill in with bone, but that process takes about a year, maybe a little longer if you're, more geriatric. Certainly way shorter if you're 10, but otherwise not too much. Yeah, that's a much quicker recovery than it going in.
Is it the same concept when you do it for the left bone fractures?
What's that?
The locking plates and
Correct, because it's that metaphyseal intra-articular type pattern. I told you I'd come back to lag screws. Lag screws was a hard concept for me at some point. It's the use of just a regular cortical screw to provide compression across a fracture to create what's called primary bone healing, where the osteon cones cut across the fracture to create bone healing. So you won't see a bunch of like callus on the x-ray. A good fracture healing when you're doing primary bone healing, you don't see anything but the plate and screws. So this is kind of how it works. So this is, again, diaphyseal bone. It's like a shaft of a bone. Step one, you reduce the fracture, get it lined up, and then you take a larger drill bit and you drill halfway, and then you take a smaller drill bit and drill the other half. And so you can see here, the first part is wider and then the second part is narrower. And so the diameter of the screw that you use is the same as this wider part. And so it kind of just slides in, and then as you advance the screw into that more narrow drill hole, it compresses the fracture as those screw threads grab the bone and it smashes them together so they can create primary bone healing. Similar, but a little bit different, they came up with a lag by design. So they created a screw that you don't have to do all the fancy drilling. And so it's smooth on the proximal end, it just kind of slides there, but as these threads grab that far cortex, it compresses the fracture. So one's lagged by technique and one's lagged by design. Super cool technology is a headless compression screw. These are awesome. So these have continuously variable thread and pitch options, so they're wider at the head and narrower at the head and wider at the tail of the screw. They're also cannulated, so a wire goes through the middle of them so you can get it where you want it. This is what we use for scaphoid fractures. Again, because they're headless, we can bury them beneath the bone and cartilage. If they were headed, they would just stick out into the joint and cause joint destruction, which we don't want. Yes, ma'am.
What is the tool you use to put them in?
So you can't see, but you do use a screwdriver.
Is a slide in there?
Mm-hmm. It just doesn't have a big head, so you can bury it beneath the cartilage. I wish I was smart enough to come up with that. I'd be a gazillionaire. All right. I was hoping this would work easier, but maybe if I exit first, it'll allow me to click that, maybe. No. Maybe I need to click it, then exit. Sorry, I'm not great at PowerPoint. Let's see. Now if I exit, maybe. All right. Again, no conflicts of interest. Acumen does not pay me. So this is kind of how a headless screw works. So again, they're variable pitches, and so as it goes in, it squishes the bone together, and you can bury it beneath the head, and it'll keep compressing until that screw gets on the other side of the fracture. Tons of torque. Great for scaphoids. All right, let's see.
Should you drive it that close to the fracture line?
No,
No, right?
never. It's gonna work. All right. Questions about screw designs before we get to intramedullary nail fixation? Awesome.
Do the screws stay in?
Where?
In the bone.
For scaphoids? I try never to remove hardware.
Okay.
Sometimes you have to. I would say the rate for distal radius fractures is probably 5%. Olecranons, 30 to 50%. Probably similar for collarbones, clavicles, 30%. The more subcutaneous the plate is, the more likely people want them out. The deeper they are, the more likely they stay in forever. What else? Probably similar to you guys, I love early motion. I want my patients moving. I want them moving aggressively. Anything I can do to help them get back to their normal functional status, I want it as quick as possible. And metacarpal fractures notoriously, they were a challenge. Do we pin these? Do we plate these? Do we cast these? None of those offer much early motion. I guess plates a little bit, but then the tendon just gets stuck to them. And so intramedullary nail fixation of fractures has really changed how I treat these and what I recommend to patients and how I recommend stuff to them. Intramedullary nails is an old topic. I think first described for femurs in the 1800s. In the 70s, 80s, 90s, really modernized, where minimally invasive, you make a small cut and place this huge titanium nail in the intramedullary canal of a femur. And it's amazing. They heal by secondary intention with this big callus model, so tons of bone and callus. Again, the implant's made of titanium, which has a really similar modulus of elasticity to bone. And so it kind of flexes with the bone versus I think the earlier generations were stainless and that didn't work out very well. And it allows for immediate weight bearing and early motion, and these polytrauma patients are up and out of bed, post-op day one, which is awesome. And so somebody smarter than me was like, well, if they can do it for a femur, why can't we do it for a metacarpal? And so they created these non-compressive screws. So, all those screws that I showed earlier, they're designed to smush the bone together. This is designed just to sit in the canal and create like rebar. So it's load sharing, and it encourages micromotion of the bone and the titanium implant to create that callus model, that secondary bone healing, unlike the fractures where we try to smush together and compress for primary bone healing. So you'll see a ton of extra bone on x-rays. That's what you want to see. So how it works. As with any fracture, we want to straighten the bone, reduce it. You start with a wire, a guide wire, and you try to get it in the top third, more away from the articular surface of the metacarpal head, and you advance it. You measure how big a screw you want to do, then you drill over that wire, and then you place it. And so, again, sorry that I'm not good at this. There's got to be an easier way. Get in and out of this thing. Maybe. Yay. Again, no conflicts. Exomed's not paying me.
The innate system is an intramedullary threaded nail specifically designed for metacarpal fractures. The innate system is placed using a simple, reliable surgical technique. Anatomically reduce the fracture. Insert the guide wire percutaneously in a retrograde fashion in the dorsal third of the metacarpal head until the tip of the guide wire reaches the proximal cortex. Once in place, make a stab incision at the point of guide wire insertion. To determine the length of the implant, insert the depth gauge into the stab incision and confirm that its tip is against the metacarpal head. Measure the exposed length of the guide wire against the markings on the depth gauge to select the appropriate implant length. To measure the appropriate implant diameter to use, under fluoroscopy, hold the pointed end of the depth gauge against the dorsum of the hand, ensuring the edges of the measurement markings align with the narrowest part of the isthmus. Typically, the 4.5 millimeter implant is used for the first, second, third, and fifth metacarpals, whereas the 3.6 millimeter implant is specifically designed for a narrower isthmus as commonly encountered in the fourth metacarpal. However, always measure as the appropriate implant diameter and length may vary. Drill by passing the cannulated reamer over the guide wire. Drill the length of the metacarpal. Lasered markings on the reamer can be used to monitor depth. Remove the reamer carefully while maintaining the guide wire position. Do not remove the guide wire. Insert selected implant over the guide wire and use the hexalobe driver to advance the implant into the metacarpal. Manually hold reduction as the implant engages the proximal fragment to prevent distraction of the fracture site. Continue to advance the implant into the metacarpal. If excessive resistance is encountered, retract and advance the implant as necessary to avoid applying extreme force upon the driver and implant. Once the desired depth is achieved, disengage the driver. Verify placement and proper reduction with fluoroscopy. The head of the implant should be buried below the articular surface. Remove the guide wire. For post-op management, soft minimal dressing that allows for early mobilization is encouraged. However, always apply medical discretion when using innate.
So, questions about the technique? Cool.
Can you just move the extensor tendon and try to avoid it, or what are you doing with the extensor tendon?
I usually just split it.
Okay.
Good question, though. That'll come up here in a second. So advantages. It's minimally invasive. It's through an incision about that big. No need for splinting. Full disclosure, I usually splint for 48 hours just for comfort and tell them to throw the splint away, on post-op day 1 or 2. I don't use any sutures. I just put a little Dermabond skin glue on the knuckle. So patients are always pretty amazed with that. Early motion. right?
What type of patient would not be a good candidate for this procedure?
Non-compliance.
Bone stock, maybe osteoporotic bone?
I think they'd be fine in most bone. I mean, unless they're 90 and really osteoporotic. I think average, it'd be fine.
When you say non-compliant, sorry to interrupt.
Yeah.
You said non-compliant, so what is that?
I'll get there in a sec.
Okay.
Yeah, other question?
What's the difference between, you said the other screws that you were showing us were for compression technique?
Correct.
And this is not? What determines, like, what about
The design of the screw, that screw is designed to provide zero compression.
But what would make you decide to use one or the other in a given fracture?
Sure. The pattern, so more comminuted, complex fractures of like a shaft or a neck, you don't want compression, but a scaphoid, which has a poor bone supply, you want to really compress it as much as possible to try to encourage it to get primary healing. A more straightforward, like oblique fracture of like a diaphysis, so a shaft of a bone, typically we try to get more primary healing to compress them. So classically, I don't know, has anybody ever seen a fibula fracture, ankle fracture? They frequently have that oblique lag screw and then a plate just to provide some extra stabilization. So just depends on the fracture, where it is, what it is. So again, early motion, right away, have them moving. Post-op day 0, I'm like, I want you in the recovery room, doing this. They're so great, many times that they don't end up seeing you because I just let them do anything they want right away, as soon as their pain allows. So it's really great. Earlier return to work. I tell them as soon as your pain allows, you can do anything you want. You can go back to work. You can build a house. I don't care. So that's pretty great. I hate pins, so no pin care. You guys aren't cleaning pins. I hate pins. I don't like them, but I use them a lot as a hand surgeon, as you know. So disadvantages. It's expensive, right? Not only are you paying for the implant, the patient's having surgery. So, more often than not, a lot of these metacarpal neck fractures, you're no surgery. So, surgery is a huge expense. The implant, the surgeon, the facility, everything is expensive, especially when everybody has a $10,000 deductible. So surgical risks, back to, I think we had 2 questions about that. So, any surgery can get infection. The implant can fail or loosen or back out. I've had that happen once. A periprosthetic fracture, so patient selection is hard. So I have long talks with these young, immature males, hey, if you're going to be punching a bunch of things, like, this is not for you. I had one young female, she punched something else and, broke at the tip of her nail. So she had a periprosthetic fracture. So, these aren't just everybody does amazing. I mean, there are complications. Surgery has risks. And then tendon injury, that we split the tendon or move it to the side or both. And sometimes the drill or the implant could cut the tendon. And so certainly that's a potential risk too. Fortunately, I haven't had that one, but I'm sure one day I will. So some cases, I think I showed this one earlier, but here's kind of all the pre-op images, multiple metacarpals, significantly displaced and angulated. I don't know if you can appreciate on the lateral view, but this is nowhere near the shaft, completely displaced, horrible injury. So before these existed, what would I do here? Do I cast these? Probably not. Would I pin them? Probably. Do I try to cross pin them? That's hard, and then they're in the way of trying to get a little bit of early motion. So do I pin them to their neighbor? Probably, but again, nobody likes pins. Would I plate them? I might be tempted to, right? So I could try to get some early motion and get them to you guys quicker. But then, tendon adhesions, more surgery to take out the plates potentially. And so I've really come to love intramedullary nails. So it's probably 15, 20 minutes for each of these to go in. So under an hour of surgery time, immediate range of motion. This 20-year-old guy's back to work in 2 weeks. It's really just a game changer in my practice. Questions about that case? Yeah.
So he's back to work in 2 weeks, and he can apply force, like if he's like a...
Not 100% at 2 weeks, but yeah.
He can show up,
Mm-hmm.
but no hammering or...
I mean, I let him do anything that pain allows. Yeah.
Is it up to the doctor, or, 'cause let's say you just let them go, is it up to the doctor or the organization for like that graded reentry for return to work after a surgery or medical event? Who grades that?
I mean, is it comp or not comp? Yeah, I mean, ultimately it's up to me to give them restrictions or not. And if it's comp, I probably am not going to put them at full duty at 2 weeks just because there's too much other noise in the background.
So you'll do restricted duty? And then
Yeah, I'd put them at light duty at 2 weeks.
Okay.
And then quickly advance them at 4 and 6. And yeah, inevitably they always are not going to be as forthright about their recovery as an average person that's motivated to get back to work so they can provide for their families. So it's cloudy, as you know.
The
Yeah.
procedure that you do, is it a Willant procedure? Do you keep them out of it?
I probably could. I don't routinely do the metacarpals Willant, but I love Willant. I do as much Willant as I can. When patients have to sit there and listen to drills and things, typically they're not too excited. So it had to be the right patient. But I would in the right person. Oh yeah, sorry.
I think the video said this, but does the screw always go the entire length of the metacarpal?
Sometimes I place them short. In femur fractures or tibia fractures, we try to instrument the whole bone, it's called. So you try to get the nail as long as you can to prevent like a bad periprosthetic fracture, so a fracture at the tip of the nail. So in the young female I had, her nail stopped here, and then she broke right at the tip, and the tip, you could feel where she broke. So maybe if I had instrumented the whole canal, maybe that would have been less likely to happen. But sometimes we put them in short, if it's, just a little neck fracture versus, a shaft fracture, you're like, oh, I'll just stop there and be done. This will be quicker. So a hard decision sometimes intraoperatively. This is a 16-year-old kid who punched a wall. So I think the spiel I give to these young adults and their parents, I tell them, at a year with or without surgery, functionally, most people are quite well. I find that with surgery, you're back doing more things faster because you're not hurting. The bone's not moving around. When the bone moves, it hurts. And, I say, you got to take into the fact the risks of surgery and the costs of surgery into your equation and try to figure out what's best for you in your life situation. But historically, in a 16-year-old with, say 50 degrees of angulation of his neck fracture, I would say most people historically would say you don't need surgery all day long. And that's kind of changed as I've gotten more into practice and how I counsel patients because I've just been really impressed with intramedullary nail fixation. Before this, to pin that, no way. I would never pin that. But this early motion, early back to everything that nails provide is changed for me. So, I tell them, your function will be good. When you go to make a fist, your knuckle will be, back there versus up here. If it's really angulated, maybe you get a little of that pseudo clawing, but you'll be able to make a fist, grip a hammer, at a year, do what you want.
Do you find that they
At the beginning, yes. At a year, I think the research has pretty clearly stated no.
And if somebody has an old fracture, but they then decide they want to have repaired, can you do that, or is it just?
A neck fracture like this one would be technically challenging, not impossible, but hard. A shaft fracture, absolutely.
What are the chances of a vascular necrosis of the bone when you do the IMN?
I think the closer it is to the head where the blood supply is poorer, it goes up. The further away from the head, the more chances that goes way down.
Even with an osteoporotic?
Correct. Yeah.
Could a medullary nail, intramedullary nail help, like length, like if you had a shortened metacarpal that was causing, balance?
Could you do like a distraction osteosynthesis with it? That'd be hard. It'd be hard.
See, it wouldn't, like she was talking about, fracture.
To do that, you'd probably need a X-fix that you slowly turnkey. So let's take a poll. This is your hand. This is your 16-year-old son. After hearing what I had to say today, don't take my biasm into account. You have your own biasms. Let's hear your own opinions. Who would want theirs or their 16-year-old sons fixed? Who would say, oh, these do fine at a year. You can have a splint or a cast or buddy taping or non-op. Who wants non-op? Well, let's start with your 16-year-old son, and then we can do your own.
Doesn't think. I would look for one thing. What's the downside? What could go wrong with the surgery, and what are the risks involved in that?
Yeah.
Over being conservative and letting it heal itself.
Yeah, so we went over that. So cost, risk of tendon, infection, periprosthetic fracture, screwbacks out. Those are probably the big ones.
And the advantage is that earlier use.
Way earlier.
Fix it.
Yeah.
Who's having their 16-year-old sons fixed? Who's getting them a cast? Okay, yeah. So it's very individualized, I think. And historically, like I said, 4 years ago, 100% of these in my practice get a cast or a splint or buddy taping, something like that.
Has there been any research on the non-operative or non-operated ones, the angulation, that 10, 20, 30 years later, as far as arthritis that's painful?
So you get arthritis when the fracture goes into the joints or intra-articular fractures. So these are outside of the joint, so wouldn't be a factor typically.
Would it affect because the glide pattern would be different, wouldn't it?
Yeah. I don't think arthritis would be a main issue for these. I think they look ugly. Oh yeah, look, when I was 16, I broke my hand, got a boxer's fracture. And then that pseudo-clawing, I think, when they start to get really angulated is an issue for patients. Okay, it's your own fracture. Who's non-opping and who's opping? Say, so now we're talking about back to work for you, manual therapies. Okay, so
Just milk it for as long as I could.
I'm gonna take my 3 months of FMLA. I'll catch you guys on the flip, right? So who's having surgery? All right, and who's wants a cast or a splint? Yeah, so it's hard. These are hard conversations that we have, and unfortunately, the way medicine is, we get paid for volume, and so you get 15 minutes to try to have this complex decision. It's hard.
I think time of year too for your children is probably a big one as far as if they're in sports or if it's summertime.
Yeah, sports. This has been amazing. Like for high-level athletes, they miss a week of competition. NFL, NCAA athletes, like amazing.
Instrument, if they're in a band or something.
Yeah, absolutely.
Catching up is hard to do.
So this kid's, I think he actually had his grandmother, I think, was guardian. Grandmother and him decided he wanted it fixed, and he was doing amazing, back to everything like within a couple weeks. And I don't even think he finished following up with me. He's like, I love this. I don't need to come back. I was like, okay, fine.
How young can you do this? Because
I think the bone has to be skeletal mature.
Okay.
You can't have an open physis.
Right.
That would not work. So what about proximal phalanx fractures? You know, right? Can we use these? Can we push the limits and start using these for phalanx fractures? I think I showed this X-ray earlier. This is the one that I pinned through the joint, right? So that's how I'd treat this historically. But man, wouldn't it be nice to intramedullary nail that? Not have to worry about pins and a joint pinned. And so I had this 18-year-old kid, and he crushed his finger in a tailgate, had an open fracture, and this thing was terrible. I mean, lots of pieces. It splits into the joint. It's really angulated. And you would love to start early motion on a young kid with this really complex, horrible injury. Before it nails, like, I don't know how I do this. Like, maybe you could get a plate and screws on there, but that's be hard. Maybe you get 2 screws there and 2 screws there, but does the joint split apart as you try to get a screw in that? That's hard. So I was like, oh man, I don't know, maybe I'm gonna try to use a metacarpal nail for this phalanx. And so I put a headless compression screw to close that articular surface. And then somehow I got lucky and was able to get that. Again, that's a metacarpal nail. That's the 3/6, the smaller one. Somehow was, by the grace, able to get that thing in there. And so his x-rays look beautiful, but of course he got crazy stuff. So not every perfect x-ray does the patient do well, as you guys know. And his motion was not great, even though we got early motion and got this fancy implant in there. But it's how it goes sometimes, despite our efforts. Last case, this was a 42-year-old guy that fell off his bicycle, had a very classic base of the proximal phalanx fracture, fairly angulated. Again, historically, I would have pinned this all day long, but we know how I feel about pins. And so I think these hardware companies realized there was a demand for an intramedullary nail designed for the phalanx. And so very recently, they came out with one. And so I got lucky enough to use it on this individual. And so they're much smaller, as you can tell. I have used it, done like a single retrograde, like in the metacarpals, but they really, obviously, because the more screws they want you to put in, the more money these people can make. And so they're designed to use 2. And so you can either cross them, you can V them or Y them. And so I kind of did a Y technique there. And this guy got moving super early, healed great, and was really pleased with his outcome. I think he also had a contralateral wrist fracture, so he was trying to rehab 2 things at once that I fixed, and he was really happy trying to get his hand going early. I think that's it. This is Charleston, my favorite place.
How many physicians are doing the nail?
It's rapidly growing, yeah. It doesn't hurt that the main company that makes these has had a huge marketing campaign. And so even to the point now that, I don't know how familiar you are with hardware companies. Anybody heard of Arthrex? So Arthrex now came out with their own version of metacarpal nails. So I think all the big players are going to come out with it. Examed, which makes these implants that I showed today, is a really small company out of Phoenix. Like 2 MDs designed them, and then they must have gotten a bunch of private equity money or something and had this huge marketing campaign. And then I think in the past few months, I want to say they have some partnership with Acumed. Do you know Acumed? So all of a sudden there's lots of money being thrown at this company to try to get more people and popularize it. Yeah.
With more competition on the market, could you expect to see a cost reduction over that?
these, they have to go through so much to get these FDA approved, and it costs so much that they can just say, I can charge whatever I want. I wish. So if you see these and you're like, I don't know what this is, and you're like, why isn't my physician wanting me to splint this? I don't understand. Now you know, hey, it's inside the bone, lots of motion, go crazy, be super aggressive, get them moving, get them going.
Do you limit strengthening or?
I don't limit anything.
Like, so you don't start with active and then progress to that, you just kind of like whatever?
I tell them do as much as they can, as quickly as they can.
They'll strengthen with their ADLs.
Yeah.
So if the patient has a $10,000 deductible,
Yeah.
what is this going to cost them to come in and have it done?
There's a lot of factors, right? So the biggest cost, I think, is probably the facility fee. So where are you having it? If you're having it at the hospital, the hospital wants $30,000, right? If you're having it at a surgery center, it can be a tenth of that cost. And then some insurances pay for hardware and some bundle it all together with the facility fee. So, a lot of factors. Those screws, I want to say, are like, I don't know, $1,000 or something.
So if the patient comes to you and says, screw the insurance, I don't even want to mess with it.
Yeah.
And is this going, if my son's good enough as a basketball player that I think he's going to get a full scholarship, so I'm going to do this.
Yeah.
However,
you're going to pay cash.
Now I can't pay for it if he doesn't get the full scholarship. How much will it cost me?
Yeah, so,
for the surgery?
everybody will offer cash price. Right. Obviously, the bigger institutions, that's complex, how they discount it. We offer, I want to say, a 30% discount on the surgeon fee and like 50% discount on the facility fee for our self-pay patients, something like that.
So with the facility fee, is this outpatient or is
Yes.
Okay.
But, a hospital facility fee is crazy, and ASC facility fee is not.
Ballpark.
I don't know.
Do you need one?
I have no idea. I have no idea.
Okay.
I'm not a biller.
Okay.
I really don't know.
You could just call, like, a surgery center.
Yeah.
And they'll tell you the cash rate. I want to say ours was like, 5, like, it depended on, like, what bone it was, but like $5,000. Like, it was cheaper than.
Yeah, so every surgical case has a CPT code associated, and every facility has a cash price.
Well, as a private practice, what I don't want to do is take my patient and say, here's your options, and they're overwhelmed. I'd like to give them some idea of where they're going to before they make their 42 phone calls. Nobody answers. They get run around in circles. They get 3 different wrong answers.
Yeah.
And then they go through a nightmare. So, that it's just been throw it out there, and it gives them a little bit more of a springboard. So when you ask, would you do it, as you did earlier, my question is,
how much does it? Yeah. So I think if you have insurance, it's, in my opinion, my biased opinion, it's always best to use your insurance even if you have a crazy deductible, because your insurance company will negotiate the fees down for you, which is lower than typically a self-pay price will be. So you're paying cash either way, and might as well have it go towards your deductible.
Sometimes when you pay your deductible, it's so much more higher because you went through your insurance, just like MRIs and everything. So
sometimes. At least for my practice, typically the insurance rate is lower than the self-pay rate. Not everywhere, right? But for my particular private practice, the negotiated insurance price is usually lower.
So how long have these, the hand instrument nails been?
How long have they been out?
Yeah.
Certainly people have using like regular screws in this manner for a while. The Examed metacarpal screw probably came out 4 years ago. And then their phalanx screws came out like a year ago or less. So pretty new. Very new. Yeah.
How many physicians are in your practice?
3. 2 general orthopedic surgeons, and then I'm the hand guy.
Are you in Emory? Are you not with Emory?
No, I'm at Academy Orthopedics. We're just a small private group, Cumming, Duluth, and Beaufort.
And who are the other two in your practice?
Jesse Seidman and Trey Duckett.
And what are their preferences for upper quarter, lower quarter?
They do general. They do everything other than hands and spine. So knees, hips, shoulders, ankles, that kind of stuff. What else?
Are you all next door to the physio in Cumming?
Uh-huh.
Okay, yeah. I'm familiar with Dr. Simon.
Yeah. He's been around a while. Just got no hair left. Just scratching. All right. Well, thank you guys so much. I really appreciate you having me.